So I was recently in a meeting when we were talking as a PCN, a primary care network, about how we redesign our mental health services. We've got this fantastic opportunity to consider the new roles: social prescribing, health coaching, mental health support workers, and a range of other opportunities in our network. And we were thinking about our mental health services. And the issue of risk came up. And I just wanted to share some thoughts from this. What we realize between us is that when anyone you're working with who's living with a mental health problem, you can assess their level of function and sort of define where their level of life functioning is. People might ideally want it to be higher, but actually there's probably a realistic level at which we can hope that people will maintain, based on their capability, skill set, their past performance, and just their context of life. So let's just call this orange dotted line, their current level of function. Now, what the team were thinking about over time was the key risk of death, of self-harm and suicide, where obviously their function drops down to zero. And this was held as a really key risk and one of the driving forces of how we organise the services. Now, of course, this is really important. It's tragic and horrendous and something we always want to minimise. But then we started to talk about the other risks that are present in these situations of people living with mental health problems over time. And that there's a risk that if people aren't supported in the right way, that actually their life function deteriorates in terms of becoming isolated, losing self-esteem. They often become unfit, particularly related to medication they're taking as they become overweight and metabolically unwell, and lose employment. And you see their quality of life and their function of life decreasing steadily over time. Let's contrast this perhaps to an opportunity where we might be able to support them a little better. We can use some of the more modern things like life coaching, health coaching, social prescribing to connect them with things in the community, and making the most of peer support, people who understand them and have people like them to support them to get the best out of life. And people become more in control, more autonomous. They're more confident, they're more physically healthy, they are often more connected with people and their community, and they're often contributing a lot more to both looking after themselves and contributing to the community. So now, of course, in life, it's probably more like this rather than a straight line for both these two, isn't it? But what you see here is that there's a real risk that we lose quality of life, not only mortality, but the morbidity side of things. And it struck me that in these conversations, we're not very good at assessing this in our systems. Of course, we'll track the number of people who have died, and of course, we'll be really worried about that. But we need good ways of tracking this risk of loss of quality of life and the opportunity cost of not paying attention to this. And I think we've got this fantastic opportunity now as we redesign new roles in our primary care networks to focus in on this, not only in mental health, but across the board. Metabolic health, physical health across the board. And I'm really interested in people's thoughts on how we capture and measure this and how we pay attention to this as we design our services.